And I believe it's time for questions from the committee. And hopefully there's a live mic there.
Good morning. Thank you very, very much for those wonderful presentations. My name is Regina Cunningham. I am the CEO of the Hospital of the University of Pennsylvania, right across the walk. So my question, first of all, sort of the whole platform of value-based healthcare, I think, creates an incredible opportunity for nurses. I mean, I think, nurses are the catalyst really to drive value in the healthcare system, and this is like the perfect opportunity for us. My question is about, we've heard as a committee over the past 2 days a lot about these incredible innovations led by nurses or within nurses leading within teams. Many of them have demonstrated very robust outcomes that clearly, again, demonstrate sort of the value proposition. Yet, one of the things that's a little challenging is that many of these seem to have what I would consider fairly precarious sort of funding mechanisms, sort of cobbled together, kind of questionable about the future long-term ability of these programs to remain in place. So what are your thoughts or recommendations around how our committee can think about that? How can we accelerate funding for some of these innovations, and how can we ensure the stability of that over time, if that's possible? Thank you.
Is this on? I think it starts with the point I made about making sure that there are metrics. It's hard for us to lobby for payment for something that doesn't have measurable outcomes. And much of the work in navigation and care coordination and those pieces are just beginning to see payment-related. You're seeing the cost per care that we were able to demonstrate. So I think it's starting with how do we build our EMRs so that the social determinants of health are a part of it, and then linking care so that you know that a registered nurse or a care partner or someone actually put in an intervention related to that, so you can demonstrate how that nursing intervention made a difference in the care of that patient over time and managing their life. But I think without metrics and without help from our data systems, I don't think we're going to get there.
So I would agree 100%. Metrics are the key. If you're demonstrating value, we're going to try to take it to scale. I also think it's helpful to think at the front end about the funding source and who's at the table. So when our governor came in, we came in with a strategy of asking for a significant amount of new discretionary funding for the opioid epidemic. So he got $100 million in the first budget. I gobbled that up and tried to build a Medicaid model about it, not to just spend it in grant money. Because if you build it in Medicaid, then there's a sustainability pathway if you can demonstrate it works. But if we had done a number, and we are doing some grant-based initiatives, but if we'd done all grant-based initiatives, we wouldn't have that sort of in our Medicaid baseline going forward. And we have partners like the Camden Coalition here who work with us on the data development and are able to help us think through. So having those players at the table and being part of the conversation, and even if Medicaid can't be the funder, Medicaid to be part of the strategy, so you think about what the sustainability model is before you invest the first dollar.
I also think we have to think about the total cost of care that the patient is receiving. And I was thinking about that with Dr. Rowe's question about the teams. And you might have the nurse-family partnership and you might have a school nurse, but the mom in the nurse-family partnership also has an OB. The child at the school nurse probably also has a pediatrician. And so how do these individual programs that are so successful fit into the total cost of care model? So everyone getting everyone looking and understanding what they're getting elsewhere. How do then shared savings? And again, here's where an intervention for the nurse-family partnership, for example, if that's then decreasing ED utilization, then is it the pediatrician that's claiming the shared savings there? So we have to step back, and we are thinking now about total cost of care in just the healthcare delivery system. I think ultimately we'll think about total cost of care more broadly. Right now, if Meals on Wheels helps keep someone out of the hospital, Meals on Wheels still has to get funded elsewhere, and the total cost, the savings is just to the healthcare delivery system. So figuring how all these pieces fit together. When I started the nursing clinic at the community center in West Philly, I set it up as a satellite of a federally qualified health center because I didn't want to create a parallel system. Our charts were the same, and when one can't be there, another one can come up. So I think it's a different way of thinking about what that team of care looks like.
Can I pile on just very briefly and say I also think leadership in our service delivery organizations has a responsibility to insist that somebody's bright idea start as a very disciplined pilot with the tools up front to collect the data and measure progress, and you go from pilot to take it to a larger scale, to test, to research, to publish, and the money follows that, and we've seen that with most of our major strategic initiatives, but that's a real role for leadership, I think, in everybody's organizations, private, public, or governmental.
Thank you very much.
Hi, I'm Bill Sage. I teach health law and policy at the University of Texas at Austin. I'd like to ask you about nurses' voices on policymaking bodies, something all of you seem to have achieved, but I gather wouldn't be quite universal. American healthcare is very resistant to change, in part because of the structure of American government, but also in part because there are all of these professional self-regulatory bodies that exert influences of one sort or another on all types of activities. Many of those have been dominated historically by the medical profession. What policy-making bodies can you think of that are relevant to your work where nurses should have more voice?
I'm going to say the RUC. That's where I think, and I think if you pick one and you focus on it and you put all your energy behind it, I think that's a really, really important point.
I think just to expand beyond that, my work really began by just simply as a chief operating officer being on the Rotary Club. And then from Rotary stepping into there where I've served on the Federal Reserve Branch Board of Atlanta and New Orleans, and then able to then parlay that into my partnership in working with the government and other entities in our state. And so I think there are multiple pathways, but it's showing up in different places where you then can parlay that into policy and influence because your resume includes those experiences which people believe then might suggest that you are prepared to talk about policy.
I think also that nurses have to know that they can have a voice in policy. I was in the Senate for 5 years, and when physicians came in, oftentimes they would talk about the breadth of all the healthcare delivery issues that they were talking about, that they were dealing with. And nurses would come in and oftentimes talk about the nursing ratio in the hospitals or possibly some safety. But I think it's to own the fact that we can talk about many of these things. I always recommend that nurses get to know their local, state, and congressional members of Congress, making sure that those folks know that nurses have a voice and can be called upon. So it's not just boards, it's also making sure that those policymakers know what ideas they're bringing forward and then can be invited. I think things like MedPAC and MacPAC who are making some policy recommendations, and also then working in policy. I think that some of the new DNP programs are highlighting the role of nurses in policy, but I think we need to do a better job saying, go be Mary Wakefield in someday, and you can actually make the policy. Know that that's a role that you can be playing, and I think it's a mind change. It's not just those boards have to invite us, but we have to make sure that nurses are thinking about the role that they can play and the voice that they can bring to that.
And all of us are used to being the only nurse in the room, and all of us have a responsibility to then reach out, nominate, bring in other people to be on those boards. There is a network. I won't call it the old girls or the old boys or any other network, but there are networks, and if we are in those rooms, our best contribution is to bring other people into that room.
I think I have a slightly less optimistic perspective on the progress that we're making in value-based payment. So let me give you my point of view, and maybe you can correct me or tell me when we're going to get to where we need to be. I went to a session not long ago where the CEO of a very famous, world-famous hospital in Boston, where I actually happened to train, gave a talk, and he was bragging about the fact that 40% of the contracts of this hospital and regional health system were value-based, and how important that was and what great progress. And I said to him afterwards, I know him rather well, I said, as I understand it, you get fee-for-service for 98% of those contracts, and then it's plus or minus 2% based on the quality measures. He said, that's right. So I said, it's really 2% of 40%, or 0.8% of your revenue is at risk. He said, that's right. I said, well, maybe you shouldn't really brag about that so much. I said, but the other thing, because I happen to have done something very bad in my life. I don't know what it was, but my punishment was that I was the CEO of a large hospital for 12 years in New York City. And it was clear to me that if it was less than 5 or 10% of my revenue, it wasn't enough to change the deployment of nurses, to change their training, to change the IT systems, and to change the way the hospital operated. There just wasn't enough juice in it. And so it seems to me that currently hospitals don't have enough financial incentive. They try to trim it around the edges a little bit to get 2%, but there's really not enough juice in it for them. And I wonder what percent of revenue it's going to take in order to get real change.
Yes, I know that Susan was going to give me the look. Jack, when we miss you in Connecticut, come on back anytime. Love to see you back there. I think we probably only have time for one response from the panel, if there's anyone. Susan, is that okay? Maybe Ellen Marie?
So there is no number, but I think that you're right. I think that we have to get to a tipping point. So a couple things. First of all, I think your point that the care delivery model has to change. And if they're still based on a fee-for-service model, we haven't changed the care delivery model. I remember early on when folks were talking about patient-centered medical homes, there was a practice manager that said, we became a level 3 patient-centered medical homes and the clinicians don't even know that we did that. Which is the opposite of what the care delivery has to change. And that's the point I made too, that the payment models need to support a care delivery model. So I would say that that hospital is now 2% more than they were probably 8 years ago. So they're moving in that direction of understanding risk. But I think that you're right, we have to get to a tipping point, and it has to get to the point where the care delivery model is visibly different than it was before under a fee-for-service model. And those financial incentives are something that we are still continuing to figure out. The current director of the Innovation Center, Adam Bowler, I would agree with you that more risk is important and is looking to see how folks can assume even more risk. We have to be careful in vulnerable populations and Medicaid because there isn't a lot of shared savings to be had, and we have to be careful how we move that forward. But having skin in the game and a reason to change the care delivery model, I think needs to be part of. It's not just a new payment model where you fiddle around the edges. You really have to get in there and change what needs to happen.
Can I make one small additional comment, which is just, I thought it was very interesting in your comments when you talked about the more people on the care team sharing in the incentives. I think that's a thing that the committee should grapple with is upside downside risk and how far the upside and downside should be shared across the care team.
No, that's it. We're done.
Yeah.
Go ahead.
Thank you, Susan. Absolutely. Time for conversations. After, I want to thank everybody on the panel. And Susan, I think you're ready for